we can.
Hi, just to let people know who haven't been before, I'm Alison Foster and I'm the Programme Director for Building Berkshire Together, which is the Royal Berks name for the new hospital redevelopment programme. And I can see some very familiar faces, which is great, and people who come and get the story every month and then get a little bit of an update. But I do see some new people as well on tonight. So what I generally do is I give a bit of an update as to where we are in the programme now and what's happening. And then we have a focus topic. So the topic tonight is health inequalities, and we've got Makini on with us tonight, who is leading on our work around health inequalities and how a new hospital, a new health infrastructure can help and should help to address some health inequalities and how we can do that. And so Makini will come on in a second and do that. So for a very, very quick canter, if for people who don't know, and a reminder for people who do, we are on the new hospital programme since 2019, 2020. There's a 3-stage process: a strategic case, an outline business case, and a full business case that all have to be completed for the Treasury before they release any funding. Being on the new hospital programme, we are in what's called cohort 4. So there are people who have gone before us and have completed their build or in development. Cohort 4 means we will be full adopters of the new way of doing hospitals, which they're calling Hospital 2.0. And that means standardized designs, modern methods of construction, which means building in a factory somewhere and bringing them on site. It means quicker business case processes. So by doing something at scale, we're hoping to make savings in terms of time and in terms of resources. So instead of us all designing our own hospitals separately, which costs actually millions in designers and architects and surveyors, and well, we still need surveyors, but in those costs, actually we all have the same guidance in terms of sizes of rooms, sizes of wards to stick to. So why not collaborate and have a suite of options for wards or for clinical areas or for admin areas that we can choose from, rather than all working on an individual hospital. So it's that kind of thing where we can make real benefits at scale. Equally, we're all doing a business case that, for example, the benefits to our local community of having a new hospital, probably 50% of those are the same as everywhere else. 50% might be quite local to us, so what are the benefits locally to us? But actually a lot of the benefits and things that you might put in a business case and you spend a lot of time doing individually, that could be done at scale nationally. So what are the things that we can do that can be done quicker? So we've done our strategic case, which is our case for change, which set out why we need a new hospital. And we know that we've got aging infrastructure, we've got £200 million worth of backlog maintenance that is actually keeping a lot of people awake at night to keep on top of. We've got a growing population, a different type of in terms of as we move forward and use more technology to look after people at home. Digital is really helping to look after people differently. We've got people coming in with much more complex needs, so the environment needs to be different in terms of a hospital. So there's lots of reasons why we need a new hospital. So we submitted that case for change in 2020, and the new hospital programme during the last couple of years has been developing what does the new way of building a hospital look like, and they've been trying to make a case for the programme funding to the Treasury, and they had that approved for the hospitals on the current programme in May. So Steve Barclay made an announcement that there was £20 billion worth of funding for new hospitals up to 2030, and that it's a rolling programme. So what we're doing, we're early adopters of designing what is the new way of doing hospitals. So by 2030, There'll be a number of hospitals that have been through iterations, but if a hospital needs to be built after 2030, you can imagine, or hopefully, the process will be a lot quicker and a lot smoother than it currently is. You will have 2 or 3 options of wards, right? I'll have that one. You can put it together. It will be made in a factory, 70% of it brought in and built a lot quicker. That's the idea in most cases. So there's been funding allocated and that's approved. We have so we submitted 3 options to take forward in 2020, which is a new hospital on the current site, a new hospital on a different site, and a partial redevelopment on the current site, which was an option that we were asked to do with a lower funding envelope. And quite a lot of working with Treasury is that they ask you to do things. What can you do for a less funding envelope? And the funding range from 700 to $1 billion, 1.3 billion pounds for those options. So, and that was for a particular build, the usual way you build hospitals, the kind of traditional way that you would build hospitals. We've now had a funding allocation range, which we now are working on, right, well, which of those options, if we use Hospital 2.0, does that get us? What does that get us? So there's quite a lot of working through to see if the allocation is right for any of our options. And if it isn't, is there an opportunity to plug that gap? So we've been asked not to share what the allocation range is, not just us, everybody. And that's because we're not comparing apples with apples, if that makes sense. So we are now going to have to look at what does a certain allocation range give us using the new standards of Hospital 2.0. Hospital 2.0, for example, includes 100% single room occupancy. So with ensuite. So it's could arguably be quite a bit bigger, depending on the different, and we've got also things that we've learned from COVID around size and circulation and things like that need to be incorporated. So we've got all these different standards now, and if, for example, we want 800 beds, if it's the same size hospital, and we want all these different departments, what does that look like using Hospital 2.0, and how much do we think that might cost? Taking into account there should be savings using standardized approach. So instead of using architects ourselves, we're using just taking the models that were done for us and applying that. So it's a bit of a formula that we're having to go through and test over the next few months. Actually, we'll do a first iteration in August, and then we'll go back again, most likely, with the new hospital programme. And if there's any gaps, we need to say how we're going to fill them, or if it's about right, what option does that deliver for us? So there's a bit of work yet to be done. It is moving though. So at least they've got the funding this year, and they're trying to allocate it appropriately. And they're also trying to, new hospital programme, trying to work out who goes when. So some hospitals need to go on a new site. They may not have a new site. If they have one, they might need planning, or they might need to buy it, or they might need infrastructure things like building a new road to it or transport to it, you know. And so there are some hospitals that have a lot to do, and some, if they were to move to a new hospital, a new site potentially, and some who, you know, actually it's a couple of buildings on their current site, and it takes less time. So they have to take all of that into account and then do a schedule. And their intention is that by the end of this financial year, which is the end of March, that they will have a schedule of who goes when and what scheme are we going to deliver. So what is the size of the scheme and all of those things. So we're working through with the new hospital programme exactly what that is. So hopefully it's a bit complicated, but we are progressing, and I'm open to any and all questions. I'm happy to try and respond to them. John Wilkins, I can see.
I saw a news item on, I think it was local television news a few days ago, which highlighted what I think was a National Audit Office report relating to Royal Berks Hospital and some others. And the message I got from the television coverage was that the project was in severe difficulties. It wasn't properly resourced, it wasn't delivering what it should be. And my interpretation of what was being said, and it's only my interpretation, was there was a significant risk that the Royal Berks project could be deleted from the programme. Now, I did look on your website to see if I could find any response to this NAO report, and I don't know if it's there or not, but I couldn't actually find anything. And
So
that news item gave a very different picture to the project than the one you've just given.
so it's funny, I've just come from a meeting today with all the programme directors and the new hospital programme team, and we did talk about the National Audit Office report, which they do every year. I think they've done every year, and it's a report on value for money, and I think you have to read it, so there'll be lots of interpretations on it. Of course, there are going to be issues with a large scale. I mean, we're talking 20-25 billion pounds worth of programme that's going to be delivered within the next 7 years, because that's what the funding takes us up to 2030. It's never been done before, and there are issues. That no two ways, there are issues. We don't respond to a National Audit Office report because that's done by the new hospital programme, because it's about the new hospital programme. So it's something that I think they're replying to in September, because there's recommendations and they will be responding to those recommendations. But in terms of us being at risk, it doesn't say that. So page 64 of the report lists that we have 3 options, that the value or the range in which we've been slotted into is 500 to 1 billion. That's the allocation range that's on a spreadsheet somewhere centrally, and that the cheapest of the options, the 3 options, is an new elective site and a new urgent care site and building. So two new buildings on the current site. So as I said earlier on, we are exploring what that range might be able to deliver, whether it's appropriate for our local population, and how much that will really cost. Yeah, I mean, there's no two ways. It's not a perfect program. It's definitely not a perfect program, but we've got people coming from National next week, which you'll see when they visit. We are very much on the program, and there's no indication we are not on the program. Somebody's put something in the chat there, so let me just check whether it's relevant to this point. He said they have to be on a new site. So Steve said that on the local news interview that the RBH would have to be on a new site. So the decision has been made, or if not, does Steve's statement limit your choice? Okay, so let me explain that. We, as part of the business case process, we've now moved into the outline business case process, and as part of that, we do some set things in what's called a Green Book Treasury process. So the first thing we do is we agree what's important. So what are our critical success factors, and what are our investment objectives? So it's technical, but what's important for us and our population, and the board agreed those. And they agree what a long list of options are to meet those objectives. And then we do an engagement exercise that goes out and asks people. And we had a survey that had over 3,500 people reply to that. We had people come to workshops and tell us what their preference was. We have people on emails and ongoing engagement that tells us what their preference was. So what comes out of that is that you say, right, what is our preferred way forward as an organisation? Not our preferred option, but it's a preferred way forward. And given some of the issues that were raised in the survey and the engagement process, which was analysed by the University of Reading, the outcome of that was that from the engagement, the sense was that people wanted a new hospital on a new site. We also currently have quite a lot of constraints to development on our site, a whole new hospital. So as I've explained around the Hospital 2.0, if that's bigger, how do we get it? How do we build it on our current site whilst delivering services? It's kind of like, I guess what I call a bit of a Tetris situation, where you decant people, you build a decant building, you demolish that, and you move people around over a number of years. And if the hospital is bigger, how do we get it in that constrained site? It's going to be really problematic. We are going to assess whether it's possible, but it's problematic. So we then we are looking and working with Reading Council to say if it needs to be bigger, what's our parameters, because we're in a conservation area one side and residential area the other side. So there may be planning restrictions to building bigger. So so at the moment, we also need to do economic and financial evaluation to get to a preferred option. So it's a technical stage. What I think what Steve was talking about was that the stage we're at, the engagement that we've had with people has spat out, I guess, of the process at the moment, that the preferred way forward is a new hospital on a new site. And the alternative way forward, which you always have to put, which has to be different from that, is a whole new hospital on the current site. But it may well change if we then get economic evidence and financial evidence that says, well, you can't afford it, it's not possible, or it's going to be too costly on a regular basis, then in terms of revenue, then we won't be able to move. So there's a lot of work to be done on the preferred way forward. So this is why communications is really difficult, because we go through a technical process, and we would say a preferred way forward because we have to land on one as part of the Green Book process, but we have to still evaluate it. So we've landed on that because the engagement told us that. That's what the engagement told us. But we have to test that. We have to test whether that's going to be appropriate and affordable going forward. So I think that's where, and that's why it's kind of really, that's why we have some of these sessions on a monthly bit to explain some of this, because a one line comment like that, if you don't understand the technical context that it's in, it can sound like, oh, we're moving. I mean, we might move, but that's nowhere near decided at the moment. That is a point in time and a preference with the information we have at the moment of our site, our ability to build a whole new hospital on the site, and the engagement process that we've had with local population over the last few months. Does that make sense? Great, okay. Any other questions? As usual, I do say to people, if you have any questions, just email us. Some people find it sometimes a bit difficult to, they don't want to raise it in front of people or have got a particular concern. Do email us, and we'll be able to hopefully be able to address some of those.
Okay, Alison, if I may, this is Richard Huff. I got a message recently, I think it was yesterday, that the West car park is going to be closed due to investigation of foundations underneath the west part of the hospital. How much is that going to affect the decision and the timeline of the whole project?
So do you mean the investigation work, or? The
results of the investigation work as to the foundations underneath for the refurb or the rebuild.
Okay, so we're doing what's called a geotech survey, which looks at what's going on underneath and around and does fancy things. It's a very thorough survey, and right. We're doing it across the whole site, which involves a lot of drilling in different places and constructing a massive drill, which you'll see actually near North Block at the moment. And it's being done in phases. So I say phases or zones. So there's, different zones will report back at different points over the next year, 6 months. We anticipate having a full report around April, around that. However, it may be that we have earlier insights depending on what the different zones come out with, but it's anticipated to finish that work around April.
Okay, thank you.
Okay. Anything else? Well, listen, we can have a listen to Makini now, and I'm going to hand over to her. But I'll come back at the end, and if people think of anything while Makini's talking, I'm more than happy to answer as well. So without further ado, Makini, introduce yourself and where you're from and what you do and all of that. Thank you.
Hello, everyone. So my name is Makini, and I work with the Building Berkshire Together team as a Health Inequalities Project Manager. And this evening, I was just going to give you guys a little brief on kind of health inequalities and how the new hospital program will help improve health inequalities in our local area. So I'm
just going to make you host, Makini, so that you can do your presentation. Okay.
Okay, so share screen, this one. Is that visible, Lynn? Can you see it, Lynn?
No, sorry, Makini, we can just see you at the moment.
Okay, let me try that again. Share screen. This one.
Us guys, the same thing happens every month, doesn't it? Because we're used to Teams, and then we come on Zoom, and it's like you've thrown us in the middle of the different planet.
Okay, I'm not sure. Let me try again. Okay. Because it's showing that it's being shared. I don't know. Okay. Bear with me, ladies and gentlemen.
So, Makini, do you want to, while you're trying that, do you want to send it to Lynn? And sometimes
yeah, I think I'll do that. Yeah,
she can do it for you.
Yeah.
I've been there, so don't worry. I've had to do exactly the same.
Makini,
so I'll email it to you now, Lynn.
Advice. That's great. You just might need to make me host again. Oh.
Okay.
So while we're doing that, we've got a comment in by Leonid. Lack of what led to a conclusion that we need a new, bigger hospital? Lack of what led to? So we have a lot of maintenance work that over the years needs quite a bit of work. So we are responsible for the lovely North Block, for example, at the front of the site, that list grade 2 plus listed building. It's not able to have many clinical services in it, and the clinical services that are in there, such as cancer and renal, really struggle because they can't make the adaptations to the site to provide a really nice environment for people who need to work in there. So and it's extremely expensive to make any adjustments to the North Block. So quite a lot of that isn't, it's derelict at the moment, and we don't have any services in there yet. We still have to make sure that it's kept safe, which costs money, and make improvements to it to keep it safe. It's a legal responsibility. The changes that we have to make clinical care good is really expensive there. Other parts of the hospital are not located because we've built on it over years. We've had extensions over years to it, so we've got things that aren't located in the right place next to each other. So as an example, we would, you know, a lot of time is wasted in moving people from, we'll say, A&E to ICU. and the staff that might have to go back and forth to that to give advice and support to each other. That's just one example, but there are a number of examples around places that are not appropriately located next to each other, as an example. If you've been, which most of you probably have been, to the hospital, just walking around it is difficult to navigate, because it's, you know, it's built on a slope, so it causes quite a lot of confusion in terms of getting around it, and in terms of being digitally enabled, there is so much that we can do to help. So, for example, I've said this before in previous, and it's a really quick example to say what's possible. In Liverpool, where they've opened the hospital and there's single rooms, it's digitally enabled. So if a sign of you getting an infection is your temperature starts to rise. If you're in a ward, by the time the nurse comes around to take that, you might have had that temperature for a while, and that infection might have been floating around for a while, and other people may well have got that infection. And hospital-acquired infections is a significant thing. It can increase your admission to hospital up to, you know, another 2 or 3 weeks, while some people need to get rid of that infection. In Liverpool, when you're in a single room, there's an alarm that goes off that your temperature is rising, so your room is sort of then signaled as such, and you're kind of barriered off, and procedures put in place to make sure that the infection doesn't you know, get to other people in the area. And they've already reported a huge reduction in hospital-acquired infections because they're able to do things like that, because it's digitally enabled for people to recognize when an infection might happen straight away. So that's kind of one area where you might have digitally enabled. There's other things like, and so it'll help us to be more efficient and more productive. But you know, the air conditioning or the changes that need to be made in terms of flow to the hospital currently would take a significant amount of resource to do that, and the position of wards and departments is not helpful either. So so there's probably a long list of estates issues that needs addressing in particular, but it infringes on the way in which people can deliver the care and how efficient and productive it can be. We've had people visit the hospital to do site tours, particularly counsellors, who say, well, whenever I go to the hospital, I get great care and I don't see what some of the issues are. But when we take them kind of behind the scenes around how we have to deliver that care, some of the compromises that we make, you know, every time it rains, there's multiple departments have to get buckets out to make sure that they capture the rain, or they cover their equipment to make sure that their equipment hasn't got rain. You know, those are the things that people manage, and quite often behind the scenes. So there's a lot going on in the hospital that needs addressing in terms of the estates issues, which impact on clinical care, make staff. You know, we want the best staff to come and work for us, and we want them to actually enjoy working and not struggle to find a changing room because there's no space for a changing room to change into. You know, there are things that staff struggle with as a result of our estate that patients probably don't know about. So there's quite a long list of why we need a new hospital. I'm just checking this chat. If the hospital was to move, what would happen to the museum and the history around it? Well, we have a responsibility, and rightly so, to maintain that building. It for health purposes. So there's, I don't know, a number, dozens of covenants on it that we're working through in terms of what we can and can't use it for. I thought it was really interesting. We went to Brighton to have a look at Brighton recently. And they've just opened a new building next to their really old Victorian building. And I'm saying this is possible, it might be possible, but they took apart piece by piece their chapel, took every single bit of it and moved it to the new hospital next door. It's just fascinating that they moved it. I'm not saying that that's something we would do, but we definitely want to be respectful of however we can of what's already there. And we have a session in September to look at some of those things. So what are the opportunities for what we've already got and keeping and protecting what we've got in terms of the heritage, particularly the museum in the North Block. There's no decisions made around that yet, but we absolutely are keen to keep and maintain that. Lynn,
if the hospital moves, will the current hospital be renovated, rebuilt, destroyed?
Again, so we don't know. So if we were to move, we may well need to sell. We may need to sell that the land, or I mean, there's options. We haven't made decisions, so we have to look at what are our options with the land that's left. So would we have maybe some kind of a hub, health and social care kind of hub on that site? So that's another thing that we might look at. So no decisions have been made because, of course, we don't know if we're moving or not. So it's difficult to make that. But we would have to look at our options. So I guess the message is we haven't made any decisions about what would happen if we moved.
Thank you.
Okay. Are we ready? Oh, I think Ian had your hand up. Ian.
Yes, it's his wife Penny who'd like to just make a comment.
Okay.
It just seems a little bit cockeyed to me in that you've invested all this time and money in consulting and seeing what we actually would like and need, and I accept that you've come to a conclusion on that. And now it's going to be a question of whether this is affordable, as far as I understand is what you're saying. But it seems a bit crazy to invest all this in sort of taking a survey and working out what is wanted, what is needed, and then to be for us to have to say, well, sorry, there isn't enough money to do all this. So, I mean, wouldn't it have made more sense to say you've got X amount of money? What can we actually do with this? I mean, I'm not a business person. I don't know about this stuff, but it does seem on the face of it, not to have been a terribly common sense way of approaching it all, because, there's been huge amounts of consultation. You put in huge amounts of work. The community has, the hospital, the staff, and so on. And then, there's going to be so many things that obviously do need doing that you've been mentioning. And yet I can really foresee that there just isn't going to be the money to do it. So it seems to have been a bit the wrong way around. Just my...
Yeah, it's an interesting one. I know I wasn't here at the beginning of the strategic outline case process, but we were, but I think it's the right thing to do to say, what does the population need, and to start with that, and then to see what we can afford, because otherwise you're not going to look fully at what's required. So what do you need, and then can you afford it? So that is what that's the way in which we've done it, and which we were asked to do it. So that's, we were told, look, don't focus on what the envelope is. If there wasn't a limit per se, what is the best for your population, and then let's start from there. And that's what we did in the strategic case. And we you try and make it value for money. You absolutely have to look at, would that deliver value for money? Is it affordable when you're doing those sorts of things? But that's where we started. And you are not the only one to raise. It's a very long, expensive process to go through the business case stages, which are set stages in the Green Book, Treasury Green Book stages, which says you must do these things in these order in order to reach your decision. So I agree that it's long and expensive.
Yeah, and it does delay the process, and you do wonder whether we're ever going to get anywhere with any of these projects when you have to go through all of this. Anyway, you're doing what you've got to do. So that's
the purpose of the programme is to try and speed this up. So generally, what we've been told is generally to get a hospital from start to finish takes between 12 and 14 years in the traditional way, and they're trying to halve that. So as an example, RAC hospitals, which is the reinforced aerated autoclave concrete, which is what we call like a concrete cancer that's sort of has got a lifespan of, it's, you know, and hospitals are holding up roofs with all sorts at the minute. They have been told they need to build their hospitals by 2030. So that's, some of them haven't started yet. So that's 7 years. So it's like, how do we make that process a much shorter process and not as timely? And those are actually a good example with some others of how we might actually do that from start to finish. Because yeah, generally in the past it's taken anywhere between 10 and 14 years to build a hospital. It's too long.
Yeah, thanks.
Okay, Makini, are you feeling okay?
Yes. Yeah. Lynn has it, so when Lynn's ready, she can.
Cool.
Brilliant. So this is just an introduction page. So I'm ready to move on to the next one. So essentially, I generally like to start with a definition, because in kind of talking to people, I've realized not everybody understands what health inequalities are. So I've got two definitions on here, one by the World Health Organization, which defines health inequalities as differences in health status or in the distribution of resources between different population groups. And that arises from different social conditions, i.e. where people are born, where they grow, live, work, and age. Health inequalities are unfair and could be reduced by the right mix of government policies. That's World Health Organization. NHS England, their definition is that health inequalities are unfair and unavoidable differences in health across the population and between different groups in society. And these include how long people are likely to live, the health conditions they experience, and the care that is actually available to them. So I just thought I'd start with a definition just to set the scene. Next page when you're ready, Lynn. I'm sorry about that really tiny graph on the bottom. I should have put on a separate slide. Anyway, so health inequalities have been kind of around for a long time, and they've had different papers and reviews talking about it and making kind of recommendations, etc. But the disparities in health really shown during the COVID-19 epidemic. And so an analysis of the data from Public Health England highlighted the deaths kind of between ethnic minorities and their white counterparts as, 2 to 4 times greater. In that really tiny graph, it's kind of comparing people with a learning disability and those without in the kind of disparity in health when it came to the COVID-19. So the blue obviously is people with a learning disability, and the red is the general population. So it's not just kind of in terms of ethnic origin where there was a disparity, but also in terms of people intellectual ability as well. The next page when you're ready, Lynn. Right, so this kind of, I've used a lot of pictures, so it's not too wordy and people don't get bored. So this looks at actually the least and the most deprived centiles in nationally. So it's kind of looking at birth weight. This is all kind of young people, 18 and under, but your inequalities start from when you're in vitro. So the first one kind of looks at, so the blue one is the least deprived and the red is the most deprived area. So the birth weight, looking at birth weight, that people in the less deprived centile in the most deprived, sorry, are 2.2 times more likely to have a low birth weight. They might have kind of under the age of 1, infant mortality is 2.3 times higher. Under the age of 5, hospital and A and D admissions are 1.4 times higher, etc. And kind of 10 to 11-year-olds being overweight and obese is 1.8 times higher, more likely. And then it goes to 10 to 17-year-olds, their likelihood of entering the justice system. And then the last one, looks at conceptions for under 18s, and for the higher deprived areas is 2.8 times more likely. So it's just a graph to kind of show nationally variances in under 18s. Next one when you're ready, Lynn. So this one, I know it's quite busy. So if you can focus on the swim chart, is it swim lanes chart in the middle down there? So this one is about the learning disability statistics. So there's quite a few statistics on there. I'll just draw your attention to the one in the middle that kind of looks at the average age of death. And this is in people with disabilities. And that's just male and females with and without a disability. So in men, the ages are much shorter in men and women, but I know it is I know for men it is 23 years and women it's for 27 years age difference in terms of how much sooner they die. So, and then there's a few other kind of statistics on there about people living with a disability and disparities in health. Lynn, when you're ready, you can pop onto the next one. Another picture. So this one kind of looks at ethnicity and kind of disparities in health and inequalities. So there are a few on there. I can kind of draw your attention to the furthest on my left, which looks at kind of maternity care for Black women. It's kind of it's a huge thing in the government kind of agenda at the moment, looking at maternity care and the differences in people's experiences and health outcomes. So that one is that Black women are 4 times more likely to die in pregnancy, in childbirth in the UK. And we're looking at developing different illnesses for type 2 diabetes. South Asian and Black people are 2.4 times more likely. And then looking at development, I'm looking on the other side in terms of developing prostate cancer, that African Caribbean men are 3 times more likely to develop prostate cancer. There are various reasons and rationales behind this, but the statistics are there and they are real and it's what happens. So I won't go into all of them, but it's just to kind of show an idea of the disparities we're talking about. Lynn, when you're ready, you can move on to the next one. So there are various types of inequalities when you're talking about health inequalities. So health status, how healthy you are, basically is one of them. Inequality in terms of access to care. So access, I'll go into access more into on another slide, but access is a big problem. And as I said, I'll go into it further on. The quality and experience people have in our healthcare system is another health inequality, and kind of behavioral risks such as smoking, physical activity, poor diets, and things like that. And then we look at the wider determinants, which aren't your individual kind of decision making, but the wider determinants. So where you're educated, where you live, your housing, and your income and things like that. So those are some of the inequalities kind of that relate to kind of health inequalities as well. Lynn, if you can pop onto the next one. So this picture is just to to explain kind of the difference between equality, equity, and reality. Some of you may have seen this kind of infographic before. So the first one, equality, is where you give everybody an equal chance. And so basically these 3 guys are trying to look at a football match over a fence. So equality, you provide everybody the same level of help. Equity means providing as much help as people need. For example, so the first guy, he doesn't need a box. The second one, in order to see the game, he needs 1, and the third one, he needs 2. So everybody then receives equity. And reality, shows the tallest guy, he has multiple boxes, and the smallest guy, he's down in a hole. So I just thought I'd show this infographic. You probably see it, you know, around, but it kind of shows, I wanted to clarify the difference between equality and equity in particular. Len, when you're ready. I will do my text bigger next time. Okay, so as I said, I'm going to just kind of go back on about access to services a little bit more. So access to services, this refers to services that are easy to get to, easy to use, timely and appropriate. So access is not about being able to go to your GP. It's a lot more than that. It's about being able to kind of speak to whichever healthcare professional you're speaking with. It's about it's just a lot more than just being able to go where you need to go. It's about being able to navigate around the hospital. It's about being able to get to the hospital and lots of things like that. So it's also kind of looking at inequitable access. It's also really important to look at the uptake of services. So looking at who accesses the services, I think kind of having audits around who actually is using the service can bring you back to looking at kind of inequity, and brings you back to who's not accessing it and who is, and trying to reach out to those who aren't. So inequitable access can be due to barriers such as anticipated discrimination, anticipated or real discrimination, language barriers, and information that's communicated in ways that are not easy to understand or possibly culturally insensitive. And these issues have often been reported by kind of Gypsy, Roma travelers, asylum seekers, and refugees. Those are common themes with those groups. Inequitable access is very important because it can result in some groups receiving less care relative to their needs. That, of course, leads on to poor experiences, poor health outcomes, and poor health status, and possibly a shorter lifespan as well. So I'm kind of just zoning in on the importance of access to services. Lynn, when you're ready. Okay, again, I'm going to bang on about access. So kind of looking at, it's kind of repeating the previous slide. It's about poor access, misinformation, service availability in areas. So I know Reading is not very remote, but there might be some parts of Reading that might be very difficult to get to some of our services. So I'm kind of having availability in that is accessible to everybody is equally important. Access to transport as well is quite important. And you might have access to transport, but you may not be able to afford it. So just also making sure that our service users know about the options in terms of help when it comes to transport, and us making sure we are providing transport to those who need it and those that are at risk of kind of poor health outcomes. Access to childcare as well, language barriers I mentioned before, and poor previous experience. So that I think is quite key, because once you have a poor experience, it kind of snowballs into everything else, poor health outcomes, shorter lifespan, etc. So I think patient experience or service user experience is really, really important to make sure that our service users come back and they use our services and they live healthy lives. Lynn, when you're ready. So I just kind of wanted to draw back to saying kind of health isn't always individualistic. So it's not always what you eat or how much exercise you do. There are things that I refer to as wider determinants that also have an impact on your health. And, you know, having a thriving community means having all the right building blocks. So a good job, good pay, a good education, transport links, resources, an environment with green space, for example, and social networks to avoid isolation and things like that. There is evidence to show that people with good social networks actually have healthier lives. So I don't have time, but on another occasion, if possible, I can go into each of the determinants and how they impact on people's health. Lynn, when you're ready. So how can a new hospital help? So when I say new hospital, I'm not saying new site or anything. It just means whether we redevelop or move. I'm just referring to either of those. So first of all, it will bring top of the line infrastructure and services that are actually tailored to meet the needs of the community it serves. And that's quite important because Reading, I know, has changed over the past 20 years. So the illnesses people suffer with would have changed because different groups of people tend to have different illnesses. So kind of making sure that the service suits the community is really important. A modernized building, as Ali mentioned before, having a digital building that can do all the things the current building can't do. And the investment in new equipment and focus on sustainability kind of works towards ensuring improved patient experience and patient outcomes. So this could include faster diagnosis, as Ali mentioned, the smart rooms that can pick up your temperatures faster and also get you treated faster, and in the long term reducing length of stay. And that is a way to save money, as well as making sure that people have longer lifespans because they're not in hospital picking up infections and things like that. And through continued engagement with our community and staff, we can ensure that we are co-producing or co-designing our new hospital. And by new hospital, I don't mean the infrastructure, but the services as well, to make sure they meet the needs specific to our community. As I mentioned before, improve accessibility. And that can mean how it's laid out. It can mean how we provide information. It can mean how we help people who come in who need alternative forms of information and communication as well. Lynn, when you're ready. This one is so tiny. So sorry, Lynn. So these are kind of the 10 building blocks for how a new hospital can improve. Okay, thank you, Lynn. Right, so these are kind of 10 building blocks for how the new estate can help improve the wider determinants of health. So I won't go through all of them, but I will, let's have a look. So let's have a look at improved design, because that kind of correlates to what I was just speaking about. So it's about developing safe, healthy, physically and culturally inclusive spaces for people, embedding community engagement and supporting digital inclusion, and quality public realm. And again, I'm gonna bang out about accessibility, but this is to affordable housing. So I've seen other kind of hospitals, they probably use their old estates to provide spaces for the community, and it can be a community center, or it can be somewhere, as one of the gentlemen mentioned, somewhere where patients' relatives can stay, or anything like that, anything that can kind of build the community. And we can also look at access to good and inclusive employment and training in estates. So I know our trust does some work within the community in terms of recruiting from certain groups, and that's a way of building the economy within certain groups as well. Lynn, can you move back up to the top, to the number 1? Thank you. Supporting community development. Oh, so this is what I was mentioning. The use of premises by the community, and VCSE refers to voluntary sector groups. So using premises for building the community, also kind of co-location of community and public services, and supporting integrated care and partnership working. So it's all kind of building community through estates. I know I only have 3 minutes left, so I won't go through the others, but I think the last slide just asks for questions. Thank you, everybody, for listening.
So thank you, Makini. So just in terms of, I hate to get technical as well with the business case. So what Makini is currently doing is looking at what is the hospital at the moment doing around health inequalities to address reducing health inequalities. And there's lots going on. There's lots and lots and lots going on. So with the there's a whole list, and you're getting around the hospital, each ward, in fact, when they, or clinical area, when they notice something that is disadvantaging, that's not the right word, groups of people, they implement they start implementing a project and try and improve it. So there's lots going on. So as part of our business case, we need to say, what is it that we're doing? But we know the opportunity to do things is way greater. So we know, for example, that our signage needs looking into, and I'm looking at Kate, who's been really helpful to us to address and tell us, how our signage, for example, can really impact on people's ability to navigate around, and therefore, if they're struggling, they might get to an appointment really anxious, and that their experience then is all different. So, there are what feels like to some small things, they're actually not small, they're huge things that will affect people's experience in the hospital.
Absolutely, Ali. Thank you very much for that. Just a quick one. I've actually walked around the hospital site with both Ali and Lynn on 2 different occasions last year. Actually, it was in December with you, Ali, when you weren't feeling very great, but it was to actually show them what it's like, with its sight impairment, using an app called Vision Sim, and also using a colorblind app, which obviously, if you see red or green as you do with your normal sight, then you're going to see something completely different when you're colorblind. That's why airports are black and yellow. So it's about making it accessible, as Makini was saying, and about making it fulfillable to the patient, that they're not arriving at the department stressed and they're late and they're worried that they've got to the wrong one, and actually they're relaxed and calm and complacent with the consultant.
Exactly. So it's a fantastic example, and there are so many of those out there. So other things that we're doing is going out, the Meet Pete team, they're the patient experience
engagement team.
Engagement team. My brain today is the London brain. The patient experience and engagement team. They go out to different parts of the community, for example, and they listen to what some of those barriers are, and they do health checks for people. So quite often people who are working 3 jobs, are single parents, have got a lot on, they might be at different go to events with their family, and so Meet Pete will go out and give them health checks, because quite often people who come through the door in needing urgent care, if they'd have got a health check just a little bit sooner, they could have managed some of those conditions. And they're not able to access that because, they have hardly any money and are working all the hours God sends, and prioritize looking after their family, and. So we're looking at what are the things that we're doing, what are the opportunities that we have to improve things. And then when we do our business case, because when you do a business case, you're saying to Treasury, if you invest in us, we will improve these things. We will do these things that will help improve. And we say, right, and we've got a track record, because here's the things that we have been doing and some of the impact that it's had and some of the opportunities that we've identified. So Makini's looking at bringing all of those things together. And she's doing that by working with the people already in the hospital at the moment to look at what we're doing and what's working and what's the opportunity. But she's also reaching out to different communities to say, how could we, if we build a new hospital or new healthcare facilities, what are the things that we could do that would really help you to access those services in a way that you're not currently accessing them? So the work that she's doing to try and find out what are the things that we might be able to do to try and address some of those issues. So that's some of the work. So if anybody has got any ideas or suggestions, and I know that I can see as well, Alice is on the call somewhere from Health Watch. So I know they do, that is their day job. That is, what they do day in and day out in Health Watch, is to try and work out how can people access information, access our services better. I saw your annual report recently, and there's lots of information in there. So we're gathering information from so many different places, because what a great opportunity we have potentially with the investment that we get. Let's try and get it right. Let's try and get it right and make sure that it addresses some of the health inequalities that we know exist. And if our buildings, or where we put them, or how we build them, helps to reduce some of that, then we absolutely have to grab that opportunity. So that's some of the work that Makini does. So any suggestions or contacts with community leaders who've got some suggestions on that? And I know, Alice, you've connected us with a lot of different people, which is great. But you know, we won't get a lot of these people come to events or fill out a survey. Surprise, surprise. So we have to go and find those people who don't come to us, because for lots of different reasons, and go and ask them, you know, how can we be more accessible to you, and what does our service need to do to help you to be healthier for longer. So that's kind of the point of the health inequalities work. Alice, got your hand up. Welcome.
Hi, Makini.
Hello.
One of the things that I'm very keen on is about faith communities. So in the sense that what have you looked at for faith communities? How do they can be accessed, kind of thing? Because there are different faiths. How do you do that quality side?
So at the moment, we, as Ali mentioned, with the Meet P team, they've already kind of embedded themselves within the community. So we are working alongside them now to try and build trust in BBT, so we can find out definitely what people would like. So it's a new collaboration, but we are working with them. But other than that, I generally try and reach out wherever I can. So I attend meetings wherever I can and just be present, so that I can just listen to people's needs and wants, and then we can kind of work with them from there. So recently I've been trying to sit in on meetings with CLASP. It's a group in Wokingham.
Disability.
Yeah. So I'm trying to sit in on their meetings, just to listen, learn, talk. And Autism Berkshire and MenCap as well, I've reached out to them as well, because I know sometimes people with learning disabilities and autism, they get forgotten when it comes to, you know, doing a lot of policies and, you know, getting their voice heard in general. So that's kind of part of it. But in terms of faith, which is what you asked, I just generally reach out to anybody I can, or we're collaborating with Meet Pete, and they've got that trust built community at the moment. So yeah, we're hoping to build on that.
So one of the things I'm just sharing is the fact that a lot of the time we tend to concentrate on Reading alone, and there are other places as well, especially West Berkshire with transport and things like that, you know, but they still use Reading as the main hospital. And I think there are groups there that sometimes you can't you can't reach out to them because they're working and things like that. But you know, there are, I would say, the carers are one of the ones that always get forgotten because
yes.
so that is the one group I think more than anything else needs to be considered as well.
Alice, I fully agree. You can ask Ali or Lynn. I bang on and on about carers all the time, and I fully agree, because they completely understand kind of what the person they care for needs, because that person they care for may not be able to relay what their needs are, but the carer certainly can. Don't worry, I haven't not forgotten. And yeah.
And we know from evidence that the health outcomes for carers is poorer. So they themselves are a risk category in terms of their own health by the fact that they are carers. So we're very conscious of that as well. Okay, any further? I'm conscious now we've gone 10 minutes over, and I actually feel it's a real privilege to have so many people come and listen to some of this, so I don't want to take the mick. and go way over time if we don't need to. If there isn't any questions, I'll let you all go. But as always, do contact me if you need anything answered that you weren't comfortable asking. We've got a phone number on the website, and we've got an email on the website as well. Okay, I hope you have a good evening, everyone.
Thank
See you next time. Bye-bye.
Thank you, everybody. Have a good night.